Okay, good morning. My name is Vijay Ravindra. I'm a adult and pediatric neurosurgeon. I work here in San Diego and had the pleasure of working both at the Navy Hospital as well as Rady Children's Hospital. And I'm really thrilled to be here, and for a couple of different reasons, and I'll show you why. But really want to thank Dr. Levy for the opportunity to speak today and talk to you guys about something. This is going to be a little bit different than the talks you've heard. And I debated about doing this for two reasons. So one, the talk is called Morphological and Ultrastructural Investigation of the Posterior Atlanto-Occipital Membrane in Children with Chiari Malformation. And my area of interest anatomically is the craniocervical junction. And of course, with that comes disorders like Chiari Malformation and Syringomyelia. And I've focused my short career on that thus far. This is a research talk, and this research is actually grant funded by ASAP, and it has been for 2 years, and we just concluded the study. So I thought it was important for this audience to see something like this and understand that the great initiatives that ASAP is kind of putting forward and helping young investigators like myself. So here are my standard disclosures as an active duty service member in the military. And as I mentioned, this project is directly funded by ASAP. Actually, I'm looking at two of the people in here that signed the checks that I used for this project, so thank you for that. And this is part of the Tim George Fellowship, and I know many of you know Dr. George and his contributions through ASAP to this whole process. So I'm just going to start off by kind of painting a picture and tell you a little bit about Chiari malformation, and all of you know this already. So, it's an adult and a pediatric disease, and a group of pediatric neurosurgeons across North America just completed a randomized clinical trial, which is what we do in medicine when we don't know the answer to something, looking at the treatment of Chiari with Syringomyelia in children, and they looked at opening the dura versus not opening the dura. So basically doing a bone decompression only versus bone decompression plus a dural graft, dural patch, whatever you want to call it. So when we think about this, you want to step back a little bit. Why does a bone-only decompression work? Is it just the removal of the bone? Well, that's a great idea in theory, but it's probably a little more complicated than that. Is it because of removal of some of the ligaments? And in specific, there's this region here. Is this a pointer also? This structure called the posterior Atlanto-Occipital membrane right here. And it lives between the bottom of the skull and the top of C1, and it's typically a very thick fibrous membrane, and it's variable in kids. Some kids it's very thin, some it's thick, but it's always removed when you're doing Chiari decompression surgery. So I wanted to know further why bone-only decompression works, because it does seem to work, and this randomized trial is going to tell us that. But we know there's 50 shades of Chiari, right? I think all of you can attest to that there are bad actors that don't improve with decompressive surgery, and they require further intervention. They require fusion surgeries. They require ventral brainstem decompression. And I just think about this, not even thinking about things like Dr. Plonsker talked about, like Chiari 3 and Chiari 2. But if you really look at Chiari 1, and we've kind of expanded this to Chiari 1.5, the symptoms are quite variable. So Chiari 1, a lot of what we talk about is incidental Chiari 1, where there's no symptoms, where someone gets imaged for, a trauma or for whatever other reason. And then there's the Chiari 1.5, which patients can be extremely symptomatic, and these are life-threatening. Things like brainstem dysfunction with stridor and sleep apnea and difficulty breathing. So there's a lot of stuff in between that we don't quite understand. Now, in this conference, I've learned a lot, and we've heard a lot of talks about brain structure and cerebellar tonsil structure and bone and dura and cerebrospinal fluid dynamics and shunting and things like that. But we collectively don't spend a lot of time on soft tissue contributions, mostly because there is a lot of variability, and a lot of it is could be based on ethnicity, could be based on gender, could be based on size, weight, things like that. So again, going back to this structure of the posterior Atlanto-Occipital membrane, this is a fibrous structure, and this is what we look at in surgery. This is the back part of the skull here. This is the foramen magnum, the spinal cord kind of coming through. And this structure here, after you remove the arch of C1, it's really sitting right there. And if you do surgery on Chiari malformations, you remove this, I would venture to say 100% of the time. And this is the kind of highlighted area here. And this is also another very nice anatomic cartoon. Of course, it never looks like this, but this is the structure in question here, okay? So previous studies have looked at this in adults, and they described it as a tension band that may affect the flow of CSF at the foramen magnum, almost like having a Ziploc bag and then putting a rubber band around the top of it so it's got a little bit of a kink there. And so this group out of Memphis, a very well-respected group, looked at some specimens from patients, and they called this the suboccipital ligament, but we're all kind of talking about the same structure. They looked at 10 cadaveric specimens and then 39 patients. And what they found, and I won't bore you with the details of the pathology, in Chiari patients, this structure was very disorganized. Okay, it didn't have the normal tissue structure that it did in patients that didn't have Chiari. So for the study that we proposed through ASAP and luckily got funded was that we really haven't studied this structure in children. Imaging is great, right? We spend a lot of time saying, hey, your symptoms aren't getting better or they might be coming back. Let's get imaging. And we can learn a lot from imaging, but imaging doesn't tell you everything, okay? So even high resolution MRI with dynamic and flow imaging and flexion extension imaging, it doesn't tell you anything about this structure in particular. And our thought was that this structure may tell us about the disease process and specifically if surgery could be successful or is successful. So our hypothesis was pretty simple. We thought there were going to be differences between kids that had Chiari malformation and those that did not. So we had two major study aims for this. One was to really look at this structure under a microscope with a trained neuropathologist and understand at really the cellular level what is going on in these kids. And we wanted to also look at the structure and then look at pictures preoperatively, look at symptoms, and eventually look at outcomes and see if it correlated with any variations in this structure. So this was a prospective study, anatomical and clinical study, where we enrolled kids that were less than or equal to 18 years of age. The first patient was consented on September 2021, and the last patient signed and consented in June of 2023. These were all patients who underwent a Chiari malformation that were being surgically treated. Okay, and obviously they needed to undergo surgery to have this structure removed. We got consent, and this was done through the University of Utah through Dr. Sam Cheshire's lab, who does a lot of tissue analysis on brain tumors. So our inclusion criteria, I mentioned it, pediatric patients less than or equal to 18 years of age. They had a diagnosis of Chiari malformation and either had Syringomyelia or some kind of symptom pattern that required surgery. And then the control group, which was our comparison group, were kids that had posterior fossa brain tumors and underwent surgery and also had this structure removed. Okay, we didn't look at kids that had revision or redo surgery, and of course we excluded patients that didn't feel comfortable giving consent for the study. So the histology stuff, I couldn't even begin to tell you about this because it's not my area of expertise, but what I want you to look at is that the neuropathologist that looked at this didn't know if it was a Chiari patient or a control patient. Okay, they were completely blinded. And in medicine, we like that because it's a completely unbiased way of evaluating something and seeing if we find any differences. And these were the stains that they did. And of course, I didn't make these slides, but I will just slowly go through them for myself and you, because again, this is not my expertise. But we looked at trichrome staining, which shows us the amount and percentage of collagen. Collagen, as you all know, is really a connective type of tissue structure that helps give our bones, our muscles, and our ligaments kind of the strength that they have. We did H&E staining, and this actually kind of shows us how much blood vessels are flowing through these areas and how cellular these areas are. We also looked at something kind of interesting where we looked at this disorganization score. And and even I can see this, that this is highly organized, less organized, less organized, and this with areas of white in between, which are droplets of fat, is extremely disorganized, okay? And that's kind of the pathological way we looked at this. Of course, any clinical study where we're going to make correlations, we wanted to look at the clinical information that was pertinent. So we looked at age, we looked at sex, we looked at BMI, height, race. There's a family history of Chiari malformation. And we wanted to look at symptoms. What symptoms were children presenting with, and were there findings that associated with this structure? We also looked at radiographic data. I think I was speaking with Dr. Eskandar yesterday that as pediatric neurosurgeons specifically, we spend a lot of time looking at measurements on MRI scans and on our X-rays. And we use that to help stratify patients and how they may behave with their Chiari malformation. But the truth is that they can be meaningless because every patient is different, and someone can have really severe measurements but not have symptoms, or have very minor measurements and have extreme symptoms. So again, taken with a grain of salt. We also wanted to look if there was a syrinx, and we also calculated the volume of the compartment of the back part of the brain. Okay. So this is the flow diagram of the study. This was a 2-year study, and we screened 43 Chiari patients and 19 control patients. We ended up with 24 Chiari patients being enrolled and 11 control patients. So our group was 35 patients and specimens in total. Just going to go over a few of the results here and kind of keep it very baseline. Is that the demographics, what I want you to take from this table is there wasn't a big difference in any of these demographic measures, which tells us as investigators is that these are comparable and populations that we can actually compare head to head. And we felt comfortable doing that. When we looked at the clinical presentation factors, we found that, although headache was quite prevalent in the Chiari malformation group, also were in the brain tumor population group here. So a lot of the symptom patterns were similar, which also gave us some confidence in the way that we looked at this. When we looked at surgical treatment, 2 patients in the Chiari group required a reoperation and readmission to the hospital, and both of those were for hydrocephalus and required treatment for that. Okay. When we looked at these imaging measurements, and again, this is on preoperative imaging, we found that they were all pretty similar, again, which was very reassuring for us, with the exception of this clival axial angle, and I'll show you what that is here momentarily, but it was lower in Chiari malformation patients, which is what we expect. Based on prior published studies, we know that this CXA value has a lot of meaning with respect to Chiari malformation and the way the base of the skull is formed in Chiari. When we looked at the meat of the study here, the pathological findings, we found that the percent of collagen was very similar between the 2 groups. The percent of elastin was also very similar. In fact, there was no difference. And fat content within the membrane was very similar. You will see here that the membrane was significantly more disorganized and more severely disorganized in patients with Chiari malformation than in control patients. And this was a statistically significant finding. The thickness of the membrane, which is at the bottom of the screen, I hope that's not cut off there, was actually similar. It was less in the Chiari cohort, but not by much, okay? And it was not a statistically significant finding. When we looked at some of the imaging measurements and the membrane characteristics, we found that there was some trends, but really nothing spectacular to write about in terms of the membrane findings and if there was an increase in the CC2 SVA, which again, previously published literature has shown that that can be predictive of bad actors in terms of Chiari malformations. Same thing with the PBC2. We know the higher PBC2, the more severe the Chiari malformation can be. And same thing with decreased CXA, as I mentioned. So ultimately, in this study, we rejected the null hypothesis. There was a difference, and when compared to the controls in Chiari patients, it was more disorganized, and it was thinner, but not by much. So this kind of changes some of the previously published literature on this anatomic structure and Chiari malformation. So to us, this tells us that this was a reaction rather than a pathological mechanism. If you think about it, a more organized membrane that's thicker with more collagen would be a stricture in that area that would cause reduction of cerebrospinal fluid flow and potentially cause the symptoms of Chiari. We didn't find that. We actually found that in patients that had a Chiari malformation, this membrane was thinned out and it looked like it was a reaction to the Chiari rather than a cause of the Chiari. And as I mentioned, this contradicts a previous study that was done out of Japan where they looked at this outer layer of this thickened dura, i.e. this dural band or posterior Atlanto-Occipital membrane, and they found that it was thickened and there was increased collagen and fiber splitting and they had calcium in there. And they hypothesized very strongly that the thickening of the dura caused syringomyelia in Chiari, and this was likely something related to a birth injury. Now, they didn't have a lot of evidence to support that, but they did claim it, and I think our study really refutes that. So I'll go off a little bit on a tangent here, and this is just my way of thinking about things, and I've had some conversations with some of the other folks in the audience, is we need to change the way we think about Chiari malformations, right? And I think that's been an overall theme that you've noticed in this meeting is we can't put everybody in one category, and that's where we don't treat patients the best that they can be treated. Think about my colleagues, and you'll hear from Mike Kelly, who's an orthopedic surgeon later today. You know, when you talk to people about scoliosis, they really think about things in isolation. They think about early onset scoliosis when kids are born. They think about juvenile scoliosis before they hit puberty. They think about adolescent idiopathic scoliosis, neuromuscular scoliosis, hyperkyphosis. These are all separate categories that independently behave differently, even though they are all scoliosis, right? Same thing with hydrocephalus. The Hydrocephalus Research Network has really spent a lot of time categorizing hydrocephalus into these categories that cause hydrocephalus. And same thing with tethered cord, right? We're beginning to understand that not all tethered cord is the same. There's lipomas, which behave differently than a fat phylum, which behaves differently than a diastem, that behaves differently than a dermal sinus tract. And if you think about grouping things together the way we do for Chiari malformation, it's a bit like combining all cancer diagnoses as cancer, right? We wouldn't do that. You can't do that. It's impossible. And so you need etiology-based research to figure things out. Now, that kind of, it's easy to say that and stand up here on my soapbox, but we don't have that for Chiari malformation, at least Chiari 1 type yet. We know there's a big continuum, but there are different ways to think about it. Personally, and the mentors I work with, and I know Dr. Levy and I have talked about this, is there's structural Chiaris, ones that are driven by the way the skeleton is matured at the base of the skull. And that is really the driving factor. Then there's flow-related Chiaris, where it's really about cerebrospinal fluid hyperdynamics. And I suspect that it's somewhere in between, but we need to get better at thinking about things holistically and then in isolation so we can answer these questions. My dream is that we take what we find in these research studies and we take them to clinical practice and we identify this group of patients here, and a lot of you fall into this group, right? This reoperation group. We need to identify patients that are high risk of failing our standard surgical techniques and figure out what we need to do to not only follow patients more closely, but maybe come up with a way eventually, hopefully in my career, to mitigate reoperation and tailor treatment that's not just the standard meal deal of a suboccipital decompression and a duroplasty, right? And that's it there. So again, why does bone-only decompression work? I don't know. I really don't know. The membrane is thinner in Chiari patients, and it's probably a correlation rather than causation. But what about the remainder of the muscle and the tissue and the ligaments? I think about, our orthopedic colleagues, and you take a kid who has an x-ray like this when they're very young, and then they progress to have an x-ray like this. And it's not just a spinal cord disorder. It's not just a vertebral body disorder or a spine issue. There's muscular involvement. There's ligament involvement. There's skin involvement. There's all kinds of factors that play into this. And ultimately, we need to change the way we think about it and do something like this. When we ask all these questions and our answer is still the same to do surgery, we haven't changed much, right? And so I think we need to translate what we're talking about on the podium and take it to clinical practice. And that's my dream with this. I'm sure a lot of you have seen this before. We need to look at things differently. I see a duck every time I look at this, but maybe there is a rabbit in there, who knows? And I think that's kind of where we're headed with Chiari malformation. And so some of the limitations of this study, it's a small number of patients. 35 patients is not a lot. You guys see clinical trials with thousands and thousands of patients. What I really wanted to do was look at the strength of this structure, but surgically it's too difficult to get a piece big enough to adequately biomechanically test it. And money. ASAP was very generous with the money they gave us, and it was really great, but we're out, And so this was great pilot data, and so now we need to take it a step further, and I think that's important to do. So in conclusion, the posterior Atlanto-Occipital membrane, it may exhibit changes related to Chiari physiology. I don't think it causes Chiari malformation. I think it's a reaction. It doesn't look to be a contributing factor. When compared to control patients, this membrane was more disorganized and it was thinner, but not much thinner. I think we need to look at future studies that characterize this structure and its pathophysiology further. And my call to action, and this is more for myself because I look at the slide every time and I get reinvigorated, is there's lots of work to be done, right? Everybody in this room is a testament to that. There's lots of work to be done. We need to look at tensile strength of the membrane, and we need to look at the way the posterior fossa or the compartment is built. And of course, medicine is moving to personalized medicine, right? So genetic and molecular profiling of all tissue in the craniocervical junction, including the muscle, the dura, the bone, and the membrane are needed. And then we need to take that and add in our technologies like artificial intelligence and high-frequency radiologic analysis. And my dream is to come up with this thing called Chiari omics, right, where we can actually look at things on a genomic level and identify how kids are going to behave. Dr. Levy in his brain tumor practice, they're doing this. They're treating kids with brain tumors using molecular signatures. I mean, you couldn't have imagined that 30 years ago. This is where we need to get with Chiari malformations. Okay, I want to thank everybody, specifically ASAP. This was a kind of a pipe dream idea that got funded, and I really want to thank everybody in this room because you made it possible for us to do this work. My hope is that, from this we will get thoughts about, non-invasive and minimally invasive treatments of Chiari malformation. And the lab at University of Utah, where all this was done, I need to thank everybody in the department there. This was a huge concerted effort and a great learning experience for me too. So thanks, and we'll probably take questions during the Q&A, I'm sure, rather than now, correct? Okay, thanks.